Hello, I am Alan Benson, and welcome to this African American Initiative Summit on Health Disparities. This summit is focused on this issue at a crucial time. During this continuing COVID pandemic and the threat of other infectious diseases, the African American Initiative is offering this topic of serious import. It is a pleasure to introduce this Health Disparities Summit with an emphasis on those that are 50 years of age and up. Now, AAI is a policy initiative organized in 2010, featuring a wide array of primarily African-American stakeholders, leaders, and operatives that come together to discuss and address the issues that confront the African-American community. As we face today's worldwide health challenges, many socioeconomic factors contribute to health disparities, including income, education, residential segregation, physical environment, and the list goes on and on. What is the impact of these factors? How do we achieve better outcomes? What can each of us do to meet these challenges? We are pleased to co-host this event with AARP of Kentucky in collaboration with Boule of Sigma Pi Phi Fraternity Incorporated. We are also pleased that we are continuing the simulcast with WLOU Radio at 1350 on your dial, as we live stream on Facebook Live and later to be posted on YouTube. Now, AAI gives special recognition to the National Black Caucus of State Legislators and the Kentucky Legislative Black Caucus for their continuing work on the front lines of our nation's capitals, fighting for truth, justice, and equality. At this time, please welcome State Senator Gerald Neal, who will serve as our moderator. Senator Neal.
Thank you, Alan. Once again, I'm very pleased to be able to moderate this particular event, and particularly as it relates to the subject matter of health disparities in our communities. We have a very distinguished group of individuals or panelists that will share their insights, their experience as it relates to this particular subject matter. And I'd like to introduce them at this time. First, we have Ron Bridges, who is the Kentucky director of the AARP of Kentucky. He focuses on equity priorities that AARP is engaged in, advocating at the state and the national level. We also have Dr. Karen Krigger, a professor of family and geriatric medicine at the University of Louisville. And in her field, she addresses causes of health disparities. Additionally, we have Pastor Alma Wooley, who brings her knowledge of AARP's commission study results and what 50 and olders think about health equity. And later in this event, we will have Dr. Louis Hargett, who will join us. He's a medical doctor of internal medicine and physical medicine and rehabilitation, who treats a wide ranges of diseases in the targeted age group and beyond. So as you can see, we have a very significant panel and a very informed panel in terms of this subject matter that we're focusing on this evening. So I'm going to begin with each of our presenters to give us some insights as to who they are, what they do, and gives us an opportunity to get our arms around each. And I'm going to begin with Ron Bridges. Ron Bridges, who is the Kentucky director of AARP.
Thank you, Senator Neal. Thank you, AAI, for the opportunity for AARP to partner in bringing this information to the citizens of Louisville and greater Kentucky. I'm blessed with the privilege of being the staff lead for AARP's movement here in Kentucky. We have 82,000 members right here in Louisville and 440,000 members across the Commonwealth. At AARP, we've long fought to build a more equitable America, a more equitable Kentucky, and to improve the lives of everyone. However, we've recognized and we're keenly aware of the fact that there are long-standing systemic inequities like discrimination based on age, on race, and those continue to block the opportunities in communities for those individuals and cause poor health and tragically even death. This is unacceptable. We see the consequences of health and income disparities disproportionately affecting not only the groups that I just mentioned, but low income, the disabled, those from LGBTQ communities, and those in isolated rural communities, which simply is not right. It is not right for this to be going on still today, which is why we fight for prescription drugs, making them affordable, and we try to expand our access to good health care, protect Social Security, and help older workers stay competitive in the job market. Fighting disparities is the core, in many respects, to the AARP social mission. Our mission is to empower people to choose how they live as they age. Therefore, when you see AARP challenging age discrimination at every turn, we're fighting to make sure that everyone has a good opportunity for good health and for the financial security. We're nonpartisan. We believe that all people should be treated fairly and equally and given the same opportunities in life. We were founded more than 60 years ago to improve the lives of older Americans, those 50 plus. We have traditionally done this through advocacy at the state and local level and also at the federal level. We provide free programs and resources designed to help folks fulfill that mission and empowering folks to choose how they live as they age. Our decades of work has made tangible progress in addressing many of the long-standing barriers to fair opportunities, and many of the social justice organizations focus on issues that we are compatible with and we also advocate for. When we fight against age discrimination, we're ensuring that older workers have fair access to jobs and promotions, getting at that economic insecurity, those disparities that impact fundamental kitchen table issues. When we advocate to protect Social Security, we're protecting those benefits that folks, too many would either be receiving Social Security or being on poverty level and not able to make meals or purchase medications. Our efforts to adjusting the cost of living each year is something to make sure that financial security is available to our older citizens. I think that, again, is our privilege to be a part of this discussion, and we will have opportunity to talk more about specific work that AARP is doing in this field as we move on tonight. So thank you again for this opportunity.
Well, thank you for being with us. And now we have Dr. Karen Krigger, who is a professor of family and geriatric medicine at U of L. Dr. Krigger, give us some context. Show us what we're dealing with here to the extent that you're able today.
Well, there are multiple factors that contribute to health disparities, including poverty, environmental threats, inadequate access to health care, individual and behavior factors, and educational inequalities. I want to go back a little bit in history to the New Deal. The Homeowners Loan Association was a federal act that started in 1933 by the US government to boost our housing market and ownership of houses across the nation. It created these residential security maps, better known as redlining, to guide the investment in the United States. They resulted in poor, overcrowded housing and exposure to more severe levels of air pollution, contributing to chronic disease. These redlined areas are restricted to industry, Black, immigrant, and low-income communities. So we have residential communities in our city and every major city in this country with industry and the pollutions that come with it. The maps were assigned grades to neighborhoods to indicate their desirability for investment. And Black, immigrant, and low-income neighborhoods were often given low grades, eliminating their access to mortgage insurance or credit for decades. And if you look at the redlining map for the city of Louisville, you'll see much of it is in the west end. We're going to have some data from the Greater Louisville Project dating from 2020. And the zip codes of 410, 11, and 12 have an area of 3 miles radius with 121,000 plus people in this area, comprised of over 51,000 families. If the west end of Louisville was a city, it would be the largest city in the state of Kentucky, behind Louisville and Lexington. It would be the third largest city. And one of the important things I'd like to touch on is that only 40% of the population in this area have access to broadband internet. It has the highest unemployment rate and highest childhood poverty rate in Jefferson County, Kentucky, and the lowest medium income, lowest educational attainment, and lowest life expectancy in years in the county. The residuals of redlining, the HLOC, that Homeowners Association Corporation Act, was disbanded in 1951, but we still have the effects of redlining in our community. There are refusals to provide delivery in certain areas of the city, particularly the West End, business loan denials regardless of credit worthiness to citizens that are living in that area, refusals to write property insurance policies, or dropping property owners insurance policy coverage altogether. Offering services to the low income residents in this area at higher prices, such as car insurance. It doesn't matter what your credit score is or how much you make, but if you have a zip code in those areas, you're going to pay higher car insurance premiums. Higher interest rates and excessive service fees or inferior products, such as payday loans, cash advantages, expedited tax returns in these areas. When we talk about social determinants of health contributing to health disparity, one of the areas we have to talk about is economic stability, and that's reflected in employment, food insecurity, housing instability, and poverty. Another social determinant of health that's influencing our health disparities includes social and community contexts of civic participation, discrimination, incarceration, and social cohesion. Education is important as a social determinant of health in terms of early childhood education development, the population enrollment in higher education, high school graduation, language and literacy rates. This was done, some of you may have known Dr. Wooley Troutman, who was our medical director in 2006, 2007. When he came to Kentucky, he started collecting data about our health. And the PBS people put together a 7-part series called Unnatural Causes. And the first 56-minute episode was focused on Louisville, Kentucky, and this aired in 2008. You can still see it if you Google either the title in Unnatural Causes or in Sickness and in Wealth. You can get the DVD or watch it on YouTube. And basically what he did was he looked at Louisville, Jefferson County, and how the differences in income and areas of where people live influence their life expectancy. And this is one of the slides from that presentation. So if you lived in Portland, District 5, your life expectancy in 2008 was about 69.8 years. The income of the people in that area, about 24,000, as opposed to the northern part of the county, District 16, with a life expectancy of 79.8 years and a median income of 79,000. And it broke down 4 different areas within Jefferson County. This is the latest edition of the health equity report that he started. So the health equity reports were reported in 2008, 2011, 2014. The latest one is 2017. They did start the data for the equity report for 2021. And that's partially out. If you go to louisville.gov and you type in the search bar health equity report, you will get that information. Some of the slides that you're going to see next are from the 2017 health equity report. And as you can see from this slide, from that report, the concentration of the Black African American population in Louisville is in those red-lined areas where we were allowed to buy houses from 1933 to 1951, with the white population being scattered and very prominent in the northern part. If we look at life expectancy in years, you will see the needle hasn't changed from the 2007, 2008 data to 2017. The white area of this map has a life expectancy of 69 to 71 years. That is in the west end of Louisville, the Shawnee Park areas bordering Churchill Downs. The highest life expectancy of years is in the northern part of the county, Parklands and Floyd Fork, Tom Sawyer Park area, with a life expectancy of 78 to 82 years. If we look at infant health, the infant mortality in the western part of our county is higher than some undeveloped countries in the world. So the dark green area on the mapping shows the highest level of infant mortality in Jefferson County. That's in the west end of Louisville. If we look at asthma, the highest number of asthma prescriptive medicines are written in the west end. Does that make sense? Of course, because that's where industry is located, next to residential areas in our city. And so the asthma inpatient admissions are highest from individuals that are living in that area. Diabetes, highest incidence of diabetic patients. We don't see that in the northern, the white area of the map here. Heart disease, again, highest incidence in areas of redlining, lowest in the areas that were considered desirable for housing. Stroke, highest incidence of strokes, cardiovascular disease in our redlined areas, particularly in the West End. Cancer, look at the difference of age-adjusted rates per 100,000, again, in the redlined areas. So I've put together some solutions as a family doc on what we need to do as a community. Louisville is my home. I am Director of Health Equity for the Health Sciences Center for the University of Louisville. I'm an endowed chair in urban policy for the Foundation for Healthy Kentucky for the University of Louisville. One of the things that we as a population need to do is to change our dietary habits. And if you're over the age of 50, you have dietary habits that are brought up in an area where we did a lot of manual labor. We were in the fields, we needed salt, we needed a lot of calories, but we don't need so many now. And if we continue with adverse dietary habits and not embracing plant-based foods more, or low sodium or salt contents, we're creating diabetes, hypertension, obesity, stroke, heart attack, cancer, and Alzheimer's disease is even associated with obesity. Eliminating soft drinks in our American diet, just taking that out. Processed foods with sodium content, looking for processed foods less than 10%. Looking for plant-based sugar substitutions like stevia. Not drinking Gatorade if we're not sweating on the athletic field, cutting grass, or doing something that is of manual labor. We need to eliminate the food desert in West Louisville with far fewer fast food establishments and more cost-effective access to fresh fruits, vegetables, and community gardening with healthy messaging. We have a 3-mile radius area of concrete residential areas. Concrete holds heat. It discourages national wildlife, doesn't encourage positive mental health. We need more green spaces to encourage daily exercise and walkable neighborhoods. We have college and high school athletes that are maintaining high caloric diets in their adult lives because that's what they had in high school and college, and creating obesity with their risk for hypertension, diabetes, arthritis, cardiovascular disease, strokes, heart attacks, and Alzheimer's. Less than 40% of the zip codes of the people living in 402, 10, 11, and 12 either have access to, equipment for, or knowledge in using computers and internet. Many economic actions in our society require the use of internet. We are a marginalized community in that part of the town. You can use the internet to order online services for food, groceries, and using online services are usually cheaper and provide discounts than doing them in person. Educational courses for adult education needs to happen, and it'll only happen if we have a computer literate population to increase employability and tax revenue in our state. This area has the highest unemployment rate, as I said, highest childhood poverty rate, lowest median income, lowest educational attainment, and lowest life expectancy in years in Jefferson County. Cannot be reversed until we address the digital divide that happens. I can't do telemedicine with my patients unless they have adequate digital resources. Seniors, especially through COVID, were very isolated if they did not have computer skills to reach out to their churches, to their physicians, to their community. Paying bills, taxes, and registrations can happen online. You don't have to watch a television commercial to choose your insurance plan, which can be predatory, if you can do the research on the internet. And I don't want to even bring up the Real ID, where you need to have computers to make an appointment to get the Real ID. And if you need documents like your birth certificate, if you need documents of your marriage certificate or divorce certificate, those are accessible only through the internet. We have to teach our citizens that just because you can retire at 62 and get Social Security, you are leaving money on the table. And you should try to wait for your full retirement age, because Medicare does not kick in until you are 65 for a great many people. We need to know how to do advanced planning for our advanced residents. We need to learn how to do the rules for long-term care planning. For instance, if you have to go into a nursing home, they're going to sell your house to pay for those expenses. But if you transfer ownership to your home 5 years before that need is met, then your family has economic benefit from your home ownership. We need to know how to shop for credit when we buy our houses and our cars, and we need to know how to build credit. Houses in this part of the city are older. They have physical hazards for seniors, such as uneven floors. The sidewalks in front of these houses may be uneven and an impediment to exercise and walking. These houses may have inadequate electrical outlets, resuscitating multiple extension cords to trip people. Poor insulation, contributing to their higher utility bills. Exposure to lead. Inadequate ventilation and lighting that can promote falls. And COVID is, we know now, well-ventilated spaces are less likely to communicate COVID to other people. Outdated plumbing, making it difficult to include handheld showers, the grab bars and the shower chairs in the prevention of falls in their home. So I am very happy to be able to speak to you today. I'm going to stop my share so I can speak to you, and I look forward to your questions, and I appreciate the time that you've given me to share with you my ideas about being over 50, which you can tell I am, in the city of Louisville. Thank you.
Well, thank you very much for that presentation. It was very comprehensive, and I think you presented somewhat of a roadmap as to how we can address these issues going forward. And all of them reflect a need to focus on policy currently and how policy changes should be made on a governmental level and various other levels. So thank you for that presentation. We now have Pastor Alma Wooley, who brings her knowledge of AARP commission study that Ron Bridges spoke of a short while ago. And the study results, what do 50 and older think? You know, what's really floating around in their minds with respect to the issues that we're talking about in terms of their health disparities, et cetera. Pastor Wooley.
Thank you, Senator Neal. I am indeed excited about this particular conversation. It is something that needs to be, the word needs to get out. People 50 and plus, we understand there is an issue, there are problems within our communities and our environment that the Black and people of color are facing things that our white counterparts are not facing. And so, and just to give some of the points that AARP wants to present is that nationwide efforts by AARP are actively engaging in unveiling numerous initiatives to support aging well. And that's one of the things that we want our 50 plus community to know, is that we want to age well. And while these critical investments benefits all older residents, it is important to apply a racial lens. And in assessing needs and appropriating resources that are equitable to undo a history of systematic injustice that has been imposed upon the Black residents and other historical nationalized communities of color. This study that was done by AARP, which started back in 2019, the research shows that most disparities in health of those aged 50 plus are associated with disadvantages that have accumulated over their life, over the course of their life. In other words, they are not random. This report shows and highlights that the systems of power and that we call the root causes that shape these health outcomes. And when we talk about systems of power, we're talking about racism, we talk about sexism, even ageism. This report addressed some of the most significant health outcomes through exploring leading causes of death for the 50 plus community in Louisville, Kentucky. To understand these inequities, these root causes, which Dr. Krigger has already said, they include income, it includes housing, transportation, food access, healthcare, social connectedness, that all of these were examined in the research that was funded by AARP. The root causes that are everything that deals with the community in which we live in and how we experience life in our community. Our access to quality housing and transportation, to those fruits and vegetables, even the experiences that we have with the criminal justice system, even the quality of air that we breathe, the economic development that is happening or not happening in our neighborhoods. All of these are very important when it comes to understanding the root causes of why we are in the situation that we're in. Our roots are planted in soil that we call systems of power. And these systems of power has isms, which are, that I mentioned before, racism, sexism, classism, ageism. And so these systems of power has shaped our experiences with these root causes, and that fundamentally impacts the health we are experiencing now. And so with this research that was done, AARP funded it, the research, but it was coordinated by the Louisville Metro Center for Health Equity. The research, the analysis, the report writing were completed by the Louisville Metro Center for Health Equity, the McNair Group, and the Wildflower Consulting. These researchers engaged with more than 750 people aged 50 plus in Jefferson County. Through this interview process and engaging with these people, these people spoke out and they literally told us, they provided us with insight about their life and their life experiences. So I want you to know that the research that was done is very important. Research, they connected with community partners across Jefferson County to include the Family Health Center, Age Friendly Louisville, Dare to Care, the California Senior Housing, the Metropolitan Housing Coalition. They received data collection from the vital statistics, from the census. They conducted individual interviews. They also fielded public surveys, and they used literature and studies that had already been conducted and are out there. We at AARP, what we expect to do with this is that we understand our mission, and our mission is to be a fierce defender and a wise friend, strengthening our community, the 50 plus community, and advocating for what matters most to families, with a focus on health security, a focus on financial resilience, and a focus on personal fulfillment. At AARP, we're looking beyond COVID. because we have to go beyond that, even though we are still in the midst of it. But one area of focus that we use is to build equity in the recovery of the terms of health, wealth, and aging. We can see an opportunity to build on our efforts to address long-standing disparities in health, in economic security, in the quality of life that we have, that is in our community with the Black and brown, the community of color. We understand that health status, that our health status at any time can force people into poverty. Health disparity that relates to race, ethnicity, gender, sexual orientation, age, socioeconomic status, and geographic region exists in all of the communities throughout the United States. But AARP believes that healthcare professionals, insurance providers, consumers, and policymakers, that we have to come together and take a step to address the disparities in the Black and brown community. All people should have access to resources. All people should have access to services and support that empowers them to live a life of dignity, not only live the life of dignity, but die with dignity as well. And regardless of their color, regardless of their age, regardless of their income, we all have a right to live and die with dignity.
Well, thank you, Pastor Wooley. We're going to want to dive deeper into that subject matter. I noticed from the presentations thus far that this thing is systemic significantly, which requires a heavy lift, so to speak, because those who operate those systems are going to have to be engaged and actually be aware of these things. You raised the name of Dr. Adewale Troutman, who brought that awareness to the forefront when he was here in Louisville. You know, he's recently passed, but his work lives on in this thing. And I'm seeing this in this discussion. We now have, thank you very much for that. We now have an individual who is Dr. Louis Hargett, who's a doctor of internal medicine and physical medicine rehabilitation, who treats an array of diseases and also treats those 50 and more above and others as well, but certainly he has tremendous expertise in this area. And I also want to point out that Dr. Hargett is involved as an official at a high level on the national level of Psi Boule of Sigma Pi Phi Fraternity, who collaborates in this particular initiative here. So we're very pleased and very welcome to have you, Dr. Hargett. Would you please give us some indication of what your engagement has been in terms of the subject matter of health disparities, and your day-to-day work actually brings you into direct contact with individuals that suffer from these maladies? If you would share. You're on mute, sir.
Yes, thank you, Senator Neal. And, you know, been hearing the discussions on inequities in healthcare and health disparities. And in my role as a physical medicine rehabilitation specialist, I see the effects of these health disparities, oftentimes in our minority and Black population. As you know, we are prone to get just about any disease process that you can imagine at a higher rate than our white counterparts and even our other minority counterparts. The incidence of stroke, the incidence of diabetes, well, the consequences of diabetes, high blood pressure, you know, leading to strokes, the incidence of diabetes leading to amputations, the incidence of diabetes, high blood pressure, different health inequalities leading to end-stage renal disease, the incidence of diabetes, high blood pressure, other health inequalities leading to peripheral arterial disease. And so I see the effects of these diseases on these patients that I treat all the time. And I see more and more, as I mentioned disparingly, with African-American and Black populations. And the good thing about, as a rehab specialist, when I get a patient, they're also assigned a case manager. And that's one of the best things that we can have, is that a case manager can help these patients with these inequalities that we just talked about in regards to housing, in regards to food desert, in regards to their social situations and all of that. And that when we try to transition these patients, we don't want them going back to exactly where they came from. We want to do better than that, because that's what led, oftentimes to the problems that they're dealing with all along. So we try to add that part of that most of them are not able to get. Dr. Krigger did an excellent job talking about the different zip codes and what happens when you live in one zip code and you can get the healthcare, you have the educational levels, you have the financial levels, you have the preventive levels that you could do in decreasing these morbidities and mortalities that we see as healthcare practitioners. And so we try to help foster a better environment for these patients going back to than what they came from, because we know the end result, if they go back into the same environment, they go back into the same social situation, they go back with the same diets, they go back to, the same lack of access, then what are we going to see? We're going to see more of what I'm taking care of now. And so, it continues to be a challenge. It is a solution and process. And also what we failed to mention today is a big issue is gun violence. And so we see, particularly in my area, I see the effects of gun violence. As you all know, only 1 in 10 of people who are killed are not African-American. We're killing each other at a rapid rate. 30 African-Americans die a day from gun violence in the United States. And then another 100 or so are injured in gun violence. And so I see on an ongoing basis, traumatic brain injuries from African-American, involving African-American males. Typically, the increase in incidences between the ages of 17 and 34 years of old, but those sequelae of those gun injuries and that violence, last them a lifetime, if they survive. So gun violence is a big area that we hadn't mentioned, at least I didn't hear that mentioned, that we need to talk about. We need to have an ongoing discussion. I know in the KMA, we're going to be putting forth that's Kentucky Medical Association, some resolutions trying to help, with the problem with gun violence. I know in the National Medical Association, which I'm also involved, we're also working on this issue of gun violence. And so it's a major issue affecting African Americans, as we know, that we need to continue to talk about and work at. And so I'll end it at that and open to any discussions.
Well, first of all, let me say thank you very much for joining in and sharing that information, all of you. I think it sets the stage for a very fruitful discussion. I want to point out that WLOU Radio and its listeners are very welcome to input in this process with questions. And if you feel free to respond to these issues that we're dealing with here today, and perhaps can provide some input in terms of how we could address these things. So welcome WLOU and their listeners. Now, let me just get fundamental here, because I'm gonna be kind of direct. In fact, with your permission, I'm going to abandon the formalities and so forth. Senator is okay, but you don't have to go there. Just call me Gerald. Let's go ahead and let's just get down to the nut of this discussion here. This sounds like a heavy lift to me. It sounds like a heavy lift, and what I'm seeing here are 2 or 3 things here. But 2 major things is the piece I mentioned earlier, the systemic piece, which is related to policies that others control. And then I see now that being played out in individual behavior that is learned over time, looking at Dr. Karen, if I may, presentation with respect to this. Where do you start with this? I mean, what does the average person do in terms of this? Where do they start? Anyone?
I'd like to say something about that.
You want to, Dr. Krigger? I mean, Karen, you might want to speak directly into your mic there, because it fades a little bit when you turn your head.
Thank you, sir. I saw a movie once with Jackie Moms Mabley and Slappy White. She was serving him fried chicken. And before he even tasted it, before he even got his hands on it, she was putting salt on the plate. It was a reflex action for her during that time. She was taking care of him and feeding him, but she put salt on it. So how many times do people salt their food without tasting it? I spent a lot of time, I was a teacher in JCPS for 8 years before I went to med school. So I spent a lot of time giving homework, telling people that sodium is a fancy word for salt, that we need to read the labels. And for our processed foods, less than 10% sodium is what should be in there. I'm a carnivore at heart. My son's a vegan. I don't know how that happened. But I have learned about plant-based foods, and I know that there are choices out there. Unfortunately, plant-based foods are more expensive than the ones that are not plant-based. Unfortunately, we don't have access to community gardens. We don't have fresh fruits and vegetables available to everybody at a cost that's efficient and effective for them. And we need to do more of that as a policy, giving land, let them grow their own, encourage them, teach them. At one point, African Americans did most of the farming. That doesn't happen. We've lost our farms. We've lost our skill sets. So how we eat is a habit. How we exercise is a habit. How many gyms do you see in the West End? Well, we've got a new one, the Nortons. We've got the YMCA. But how many people go there or even know how to afford it or get in touch? There are things that we need to be teaching people about exercise in their homes. Things they can do in armchairs, weights that they can make with half-gallon milk jugs filled with water with graduated increases for weight. We need to do a better job of teaching our seniors how to take care of themselves, because the bottom line is there's an inverted triangle. My age group is at the top of the triangle and the younger ones are at the bottom, and there's simply not enough of them to take care of the needs of our society. We have to stay as healthy as we can for as long as we can.
Sorry, I hope I didn't cut you off there.
No, I was just saying, thank you very much for that opportunity.
Well, I'm hearing this, and I'm hearing you saying that this is going to take education, and it's going to take massive education. But and I see signs of things changing in the community, or at least I see people making efforts, opening up stores where you can get vegetables as opposed to meat-based foods and so forth. But it seems to me that it's an uphill battle. It seems to me that something more has to be done in terms of making education more than just a word, that we need to educate. How do we deal with this systemically? How do we address this? Anyone just pile in whenever you feel like it, but how do you think that we can do this? We know we need it. How do we do it?
Well, I believe that it's going to take all of us working together. Even as a pastor, I have to talk about it in the congregation. I have to stress the importance of exercising, the importance of eating proper foods and stop drinking soda and all of these other things that are just needless calories. And so it takes all of us to make sure that this education is being taught. And so everybody within the community has to come together and work towards this goal of teaching and demonstrating what it takes to live healthier lives.
So Ryan, you have an organization, AARP. You have the whole Commonwealth of Kentucky to work with. You're dealing with a lot of people. You have a lot of members. You have folks that are out there. Do you find having this communication and contact with your membership that what you're saying in this particular area is having an impact?
Senator, I absolutely believe so. It's capitalizing on the opportunity to engage all those audiences in this discussion. Many of the rural Kentuckians, Dr. Krigger's mentioned access to broadband and the delivery of health and clinical information that can be done at home rather than traveling hundreds of miles to medical centers offers something that eliminates their disparities that they're experiencing. As we build a common thread around everyone benefits by addressing systemic disparities and convincing a greater number of folks that there are solutions that will benefit us all, I think we can move forward. One of the things that AARP's research arm is highly respected, has projected by 2030, $1.6 trillion will be lost due to unrealized life expectancy. That's premature deaths. And in fact, 1.1 trillion in the year 2030 will be lost consumer spending because of folks have prematurely left this place. So it's incumbent upon us to try to build bridges and understanding around these issues. Dr. Krigger and Pastor Wooley mentioned physical activity and exercise. In September, AARP is going to be unveiling a fitness park in West Louisville that will allow folks in the neighborhoods to come out and use an outdoor circuit of fitness equipment. We're engaged very deeply with the age-friendly Louisville movement and age-friendly across the Commonwealth to try to get communities to address issues such as transportation, which has implications for education, employment, access to physicians. So there's a synergy of things that AARP has chosen to execute on in terms of meeting our mission that I think build and sort of upon each other to begin addressing. But it's got to be something, as you said, a heavy lift that involves expanding our coalition, if you will, to address something that will benefit everyone as we make the changes that need to be made.
I
Gerald.
guess I'm sorry, go ahead.
Oh, I was going to comment, if I may.
Please.
I think there are two big issues that come into play. And that one is to have the people with the means to become involved or engaged. And what I mean by that is that, for example, the new facility that Norton's put up in the West End, Norton was an entity with the means that they could get things done to put in place for people to be able to utilize. A similar concept with the hospital that is going up in the West End. So you got to have people or corporations or sponsors or get people engaged that have the means and the necessary money, influence and to get them to have an interest, that they feel would benefit them into coming in impoverished neighborhoods and areas and putting up a building like that, building a hospital like that. And then the second part is that you got to get the people who are in those areas who have influence to buy in to what the people with the money and the means to do it, to get those people in those areas engaged, i.e. pastors, i.e. council members, i.e. leaders in the community. So you got to have those parties involved in order to make things happen. And with that, you can get what we talked about, getting people educated, getting people the food deserts, getting the transportation, getting everything done. But you got to have that joint, and because we all know the money's in the East End more than likely. So you got to get people in the East End interested in coming or investing in the West End, and then you got to get the people in the West End interested in getting engaged with what those monies and services can provide.
Well, I think it goes even beyond that. I mean, certainly those in East End are welcome, anybody who wants to invest, but you also have a public and private situations that are leveraged by government that plays a major role. Yeah, and I think it's essential to that process. You sound like Pastor Wooley, because it's an all hands on deck kind of
Exactly.
approach. And I think that's exactly what she was saying. You know, I'm interested in knowing, I'm a policymaker, right? And then if you take the Metro Council, they're policymakers, the ones that are on the Metro Council. And although a lot of people think that they're not involved in politics, everything that happens is actually generated by policy, and it affects their lives each and every day. And I'm not just talking about what we do, I'm talking about what we don't do as well. So I'm interested in this. What, if any of you just jump into this, what is the single factor, if you can isolate it, maybe it's more than one factor, that contributes to health disparities more than the others, that you think legislators ought to be focused on? And I'm talking about not just on the state level, the metro level. You can bring the federal level into this. What do you see as the major factor, the major contributing factor that you think, from a policy standpoint, that legislators should be, pulling out all the stops for? That might be an unfair question because there's so much to deal with, but go ahead.
I want to take a shot at that because I had hoped by the time I stopped practicing, we would have universal health care for everyone.
Okay, we're having trouble hearing you.
I'm coming closer.
Now you're good.
All right. I wanted to take a shot at it because I had hoped by the time that I finished practicing that we have universal health care. Kentucky has the worst health outcomes. I mean, there are about 3 states below us, but you can name any disease and we're at the bottom. We need to have equal access for primary care. We do a great job at doing some very fancy things. But the basic line is there are people who can't get blood pressure medicines that will save them from going into dialysis. There are people that have to pay an arm and a leg for insulin to control their diabetes that we could avert by they see all of these medications on television, but their insurances may not cover them because of the cost. And we don't have a system in government that limits the cost of prescription items. There are 46 plus Medicare D plans in this country. There should be one. If I have to spend, I can't talk to the people on pre-authorization. I do not have the patience. But if I have to fight for every drug that somebody needs, that takes away time from seeing patients. We should be able to do a better job. Of all the developed countries in this world, we're number 15 and 16 in terms of life expectancy, coverage for our citizens, and morbidity and mortality of chronic illnesses. And that's unacceptable. That's unacceptable. If you ask me what we need to do, we need to make health a priority, and we need to make the access to health accessible to all.
Well, as you know, this whole process of how health care and those who are in the professional realm of providing health care, how that's evolved over time in the United States of America has been a tug of war and a rocky road, to say the least. But there seems to be some light. You mentioned insulin, for instance. Insulin is the charges are very high rate. And now we have some legislation that's passed that allows negotiation with those who provide certain kinds of pharmaceuticals, et cetera. So do you, from your understanding of what's happening now, does that hit right at the heart of it? Or is there much more that needs to be done?
That's a beginning.
Yes, go ahead.
That's a beginning. For instance, health insurance. I have patients that got jobs and they have been on Medicaid and they were so excited that they had their own, quote, private health insurance. But the health insurance that they had copays and deductibles of $3,000 to $5,000 and only covered one physical exam a year and one acute visit. So they got this because it was what they could afford, not realizing that their diabetes, hypertension, hyperlipidemia, all of those things were not going to be covered on the routine visits that they need. So yes, I am very happy that we're capping and we're negotiating drug prices. But until people have access, equal access to health care, it's not going to change much. Then of course, they've got to get to it. And then in the case of COVID, the electronics are wonderful, tech is wonderful, but if you don't have a broadband with, then you can't see your doctor can't see you, and talk to you at the same time. Do you understand that? That when I do a telemedicine visit, now during COVID, I could see patients under the telemedicine umbrella, just audio, but now that's over. So now I have to be able to see them and talk to them to offer them a telemedicine visit that's reimbursed through their insurances. So it is a heavy lift. But you know what? We're a capitalistic society. We just have to find a way to make money through it, and then we can get it done. Marketing. Just market health behavior. Market that it's important that it's cheaper to take care of your chronic illness than to wait for it. But we can't expect people to give up food and shelter to pay for their medications and their doctors.
As another indicator, Senator, of the capitalistic approach to doing what needs to be done in this country, the insulin portion of the Medicare negotiation bill was eliminated at the last minute.
Yeah.
Strong lobbying from pharma. So those folks that are trying to deal with the expense of their insulin continue that even after the passage of this historic measure this past week.
Mm-hmm.
Well, thanks for that observation, correcting that.
And my opinion is that I think poverty, and goes with that in my mind, is education. Because if you don't have anything, then you don't have access. You can't buy anything. So just, the better off you are from a poverty standpoint, the more access you have to healthcare and everything that comes with it. And so I think education is one of the best ways to get out of poverty. And so I think education is a big part of impoverished people. And I don't mean everybody needs to go to college. I think that as people are on a lower rim of education, they tend to have more lower paying jobs, less ability to provide for their families with food, healthy types food. And so it affects the whole spectrum. So I would say poverty and education would be the biggest barriers in regards to health inequality, because if you can afford it, you're not in those zip codes that you mentioned, Karen, and you're able to get you go to Whole Foods, and you're able to buy your medicines, you're able to do your copay. So poverty, in my mind, and education as a follow-up are the two biggest barriers affecting health inequality.
Well, let me jump in there for a minute. I can't say anything negative about that. Obviously, education, everybody on this call here has risen to their station, whatever that may be, because of a number of factors, but certainly education. But my observation is that the vast majority of people who have historically found themselves in poverty is not due to their desire not to do something, but because the system is constructed in such a way that they don't have access to that. And let me point this out too. I think that people do those things that they feel are attainable, and it's a big push for someone who's been bombarded all of their young life, all their middle life, and higher, to then expect a turnover in this regard. Now, that's just an observation of mine. Doesn't negate anything you just said, but it does frame the fact that this is a major, major problem. I think it's going to take massive work from government, from those institutions, nonprofit or otherwise, that are intentional, that there's a responsibility for those who operate in the realm that I operate in to face that reality and step up to the plate. And we've done a little of that. I mean, just think about it. In West Louisville, for instance, you mentioned the hospital that's coming to West Louisville. I think that's huge with respect to that. We just had about 30 million and some other $1 million focused on groups of those who live in the community and institutions that focus on the community to do intentional work from their perspective with respect to this. We have groups of people, individuals who have an entrepreneurial spirit, who are bringing plant-based foods into our communities and advocating for that and giving us an opportunity to access that, at least to dramatize the fact that this is very important. We have a park that's being extended into West Louisville, and not to mention the park that Ron just spoke of, the exercise equipment and so forth being made. The question in my mind is, I think it's just not enough. I think it's going to have to be much more massive. And I think that has to come from government and private coalitions, which is the way this thing has to be approached. What do you think?
You know, as it relates to the 50 and above, we're fortunate in many respects that Louisville and many of the healthcare providers, the entrepreneurs, have touted Louisville as the mecca for innovation around aging care. And if they're developing these tools and interventions that are national in focus, why not make a difference here in Louisville, in the West End of Louisville, all through Louisville, and make a difference in those lives, and then you replicate across the country. But if you're touting yourself as being the capital for aging innovation, let's take care of our elders here and mirror that for our young folks, on and on. I think when those private-public partnerships come together, we need to be at the table and advocating for those sort of indigenous directed interventions. And one final thing I would say is having the momentum. I think many public-private corporations have all presented their equity statements and their dedication to making equity something that not only is an internal focus, but it's their external public-facing agenda. I think we, AAI and AARP, should create a scorecard and encourage them to continue their work in creating these equity agendas, but help them figure out how to measure what the success looks like and how that success is occurring. And I think that should be replicated across the country.
I think that's a fantastic idea. We're talking about transparency, and we're talking about tying measurables to that in terms of that. I think that's great. We're getting ready to lose, if we have not already lost, our WLOU listening audience. If we haven't, we want to thank them for joining in, and from AAI and AARP of Kentucky. And we will be having other topics of concern that you can join in on. But we shall continue with this particular discussion here. So I keep getting back to it. In fact, one of the folks, I know we're focused on 50 and over, but Pastor Wooley, one of the listeners said, how do your researchers address this with the younger African-American community? Now, you know, I think that's relevant because those folks that Dr. Hargett deals with were once younger, and they find themselves where they are because of habits they had before they reached 50, and they continued throughout. So was there any element in terms of that research that dealt with that aspect of health disparities and how people viewed it?
Well, majority of the research that we did focus on the 50+ community, but we also found out through this research that when it comes to life expectancy, that the Black community, we are dying at a faster rate. And that's at every age until you're up to 85. At every age, we're dying faster than any of the of our white counterparts. And so it's important. Something has to be done.
Well, okay, so you do see the need for more
definitely,
deep with respect to that.
definitely.
One other thing, I got to go back to the scorecard thing. I tell you, you really piqued my interest there. Ron, and I dare say that our collaboration with Sigma Pi Psi Boule of Sigma Pi Phi, that maybe a joint initiative between AARP, Psi Boule, as well as AAI may produce and maybe solicit the involvement and embrace of many across the community. I think that is a really significant idea, because this is so huge. I think most people don't even understand the complexities of it. We can point out different things, but and we can talk about this forever, but who's doing what that's central to having better outcomes in the areas we're talking about. Dr. Krigger.
What you doing? I want to.
See, that was unfair. I didn't pose a question.
No, you didn't. You're just assuming I was ready to speak about something.
Well, you're always ready.
I want to circle back to Lewis's comments about poverty and education. My plumber makes more per hour than I do. And that has always been in the last 30 years. When you talk about systemic racism and you talk about education, those are opportunities for people to have good outcomes. But how many of our people of color are given those opportunities in the school, or know that they can be a lineman for LG&E and make a great salary? Not everybody has to go to college. And you're right about poverty. If you have a way of providing for your family with insurance and a home, it's not just physical health, it's mental health. And you will live in areas where you can walk in the afternoon or evening and set your mind in a positive mental, you're not dodging bullets, you're not dodging potholes, and you're not dodging holes in the sidewalk. We have to work on all levels to make our city, our commonwealth, healthier. We have to, I heard that word, engagement. We have to teach people what it is like to live differently than what they're living now. You have to show them. There was a time when all people of color did live in the same area. Doctors, lawyers, politicians, but that's not true anymore. So there is a segregation within communities of color as well. And so if we represent 15% of the population of this country as African Americans, but less than 5% of the doctors in this country are African Americans, we got work to do. And it's not just doctors, it's engineers, it's any profession that you want. And Pastor Wooley, our 30th health fair is coming up October 1st. And I was looking at the menu that the men's club was going to cook to give for free lunches. And then I had the president of the men's club. I went to him, I said, when you guys talk about this, can you think about plant-based? I didn't get very far. The hot dogs are still going to be there, and I'm going to have to fund the plant-based brats. And I'll put some of that stevia tea on the thing, and they can sell that and see if that goes before the soft drinks. It is a heavy lift, and it's going to have to be from the bottom up and the top down, and all of us have to play a part.
You know, at the end of the day, the first line of defense is the individual person, right?
Yeah, yeah.
The first line of defense. So I'm gonna go to Dr. Hargett on this, because he not only treats individuals that we're talking about, a category of them, but also he deals in rehabilitation. So Dr. Hargett, in your experience, I'm talking about human behavior here. Let me give you a little bit of background. When I had COVID, was flat on my back, was trying to recover from that piece. It was a slow process, but eventually I went to rehabilitation. And I did everything they said. Boy, I tell you, I was in great shape. You know, my blood pressure came down. I was in great shape, but I didn't keep it up.
Right.
Now I'm still trying to deal with it. What is your experience? Now we're talking about human behavior, learned behavior, opportunity and excess related to that behavior. In your experience, you have a long history and engagement in this area. Give us some insights on human behavior. Maybe what you see, and maybe something that will encourage us in terms of someone who got it and kept going.
Yeah. The key is that behaviors are best learned when you're young. As far as positive behaviors, negative behaviors, all those are learned when you're young, and they tend to follow through unless some major event happens to where you decide, and that's the key. The individual person has decided to change. And like I say, I see the consequences of long-term smoking, diabetes, high blood pressure, et cetera. And I have patients that say, Doc, I'm through smoking. I'll never smoke a cigarette again. They've had lung cancer, had a lung taken out. And it takes that kind of traumatic event, though, to let them see that, what they've been doing, and people have been telling them over years, that they finally get the message. And that's the point. The person has to get the message. I give you a good case in point of a patient that had neck surgery and was partially paralyzed and went into the rehab center. He was alcoholic. He fell and broke his neck. And so anyway, they had to fuse his neck and went in the rehab center, stayed several weeks, went home. He's able to walk some, continued to get better. We sent him to outpatient rehab. And so I'm in follow-up and finally let him transition away from me. Well, about 6 months later, I get a referral to see him again, and he'd fallen again. And the problem is that he was still drinking. And so the point is that he fell and he broke his neck again. Luckily, it wasn't too bad, and they could stabilize his spine and all of that. But he told me this time, he said, Doc, I'm through with the liquor. And so the point is that you get people, and been drinking all his life. He's been told over and over not to drink, but it took these kind of events. And so unfortunately, this is what you deal with, these unhealthy patterns of behavior that people develop over time. And it's so difficult, to stop smoking. That's a difficult process. To stop drinking, that's a difficult process. Now, these are extremes, but we see this all the time. And so, and then as you mentioned, the diabetic, refuses to check their blood sugars, refuses to watch their caloric intake, the carbs and all of that. And it takes an amputation to make them, or the person on dialysis. So, unfortunately, it takes these learned behaviors that they've been into these patterns for 20, 30, 40, 50 years. And it's very difficult to do that, but it's the patient that decides. And I've had them again over the years, one event, they'll say, I'm through, I'm done. I'm going to do what's healthy for me. I'm not going to do it anymore. And that's what we see.
Well, let me ask you. So do you see the same factors contributing to health disparities in rural and urban areas? Or what are the differences, if any differences? Anyone, please. Are we looking at the same thing in terms of contributing factors to health disparities?
I think
rural
so.
Versus urban.
I think so. In my mind, the only difference between rural and a city is that you just got more people around and you can do more, but they have the same problem. They have alcoholism, they have violence, they have diabetes, they have lack of access, they have poverty, they have inequality. So you see the same things, but just not in the numbers, simply because the numbers are not there. So I think you do.
We see the same ravishment that opioids has done in the
That's a good example.
Rural communities, being the canary in the mine. And we talked earlier about the impact now it's having in our communities, urban communities.
Well, let me turn this around a little bit now. We keep talking about people who have learned behaviors. It's not like they were born with learned behaviors, right? So they are born into a system of behavior, which I guess deals with all these things we're talking about, excess and otherwise. But also there's the individual choice that people make here. Where does that responsibility cross over into, let's say, government's responsibility? Where is it the individual responsibility versus the collective societal responsibility to act?
A hard one. If you are looking for health insurance and you're a smoker, some of those insurances require me to do a test to verify that you don't have nicotine in your system. Although it's an addiction, an addictive substance, and we all know that addictions do take a long time and you have the potential of relapse, even when you get to sobriety for your alcohol or your drugs or your tobacco. But I also think that education is the key to this. If people don't see any other way, if everybody around them smokes, Uncle Joe lost his leg and that's just what happens because he smokes. If you don't see another population, if you don't see another way of life, then you don't know what to aim for. Does that make sense? If I'm going to ask somebody to stop smoking, I'll make a joke. Okay, you guys are going to work together, husband and wife, and the money you save, put in a jar, and this time next year go to Bahamas. That's a tangibility that they can actually see what's happening, that they can plan for. That's a marketing tool, I think, for me, to get them to do that. And consistency, wait. I went to Eastern Europe and I thought, man, I would never be able to practice medicine here except for the HIV, because my bread and butter in Kentucky is diabetes, hypertension, and obesity. You don't see that over there. They walk everywhere. You don't even see a pair of tennis shoes because they wear good leather, black shoes for walking. We have developed things in our culture that people want and they think they need, but they're not healthy. And our government has to make those decisions. Did you know that January this year, the government started a program where they're going to decrease the amount of sodium in processed food gradually over the next 10 years? Because they realize the high level of sodium is contributing to heart attacks, strokes, and hypertension. We created that. Splenda wasn't approved by the FDA in the 60s until Dick Cheney, as a lawyer, got it through the FDA. The company hired him to make it through because it doesn't help you lose weight. That's why the plant-based stevia is supposed to be better for you. We have things that have passed through our systems in government here that have contributed to our problems of obesity and poor health. When you can get a big thing of sweet tea for $1, and it's actually cheaper than if you got a smaller one, what are we telling people? Bigger is better? Yeah, not necessarily if we're talking calories that are empty, if we're talking foods that are not healthy. All the snacks that are on the supermarket shelves when you get ready to check out, how many of them have iron in them or calcium or anything that's of benefit? They're empty calories. But we, as a government, we need to say, this isn't good for our country. We can't afford the healthcare costs for these things. People got rich off of them for inventing them, for marketing them and selling them, but the cost came to the citizens of the country.
Okay. Well, let me shift gears just a little bit, because sometime earlier we were mentioning something about mental health.
Mm-hmm.
And this mental health piece is huge. I remember there was a time where there was a big question as to whether they could hold someone in an institution because they were deemed to be quote unquote mentally ill, whatever that term means, but that because they could be medicated, then they weren't necessarily out of control if they were in an institution. So they had a court say that, well, you can't hold people against their will like that. And now it could be argued, I would say, that there are a lot of people who went off their meds or really had some challenges or didn't have the proper support. And you see them every day in the street, unsupported for one reason or another. What can we do about that, if anything at all?
A great many of those people are self-medicating their mental illness with the substances that we see the after effects of, whether it's drugs, alcohol, heroin, what have you. We do need to give people support, access to their medications, and we need to keep up with them. And so there are some medications that you can give by injection once a month. We have a lot of people that have come back from wars that we've had in the last 30 years that have had head trauma, or they have had PTSD, We've had families, if you look at the families in the West End, that was a slide, Louis, that I didn't put in, that showed the number of homicides in Jefferson County concentrated in the Shawnee, Portland area. Each person that was shot, who had a family and a neighbor, experienced some sort of trauma. Each child was a collateral damage if that was their family member or their neighbor. So mental illness isn't just the ones that have schizophrenia or psychosis that are wandering around the streets. That starts when we talk about root causes, that starts very early on to exposure, and that's where we have a responsibility. I think, Senator, that you passed a bill this season in your legislature in which we're going to make numbering the number of students in the schools and the number of mental health professionals that are available to those students all over the state, so that we know, do we need to make more therapists? Do we need to train more psychiatrists? Do we need to have greater awareness of adverse childhood experiences? And adverse childhood experiences don't stop with a child. There are adults out there that are living and they don't understand what has happened to them, but they raise children with the same kinds of experiences that they had unintentionally, because that's the model, that's what they see. They don't know there's a different way. So we do have to attend to the issues of family. And if you want to see a silver lining in COVID, people got off the rat race for about a year. I believed truly that in 2008, when the economic bubble burst and people were laid off, the folks that were left, they didn't hire those people back in those jobs. So the people that were left are today doing the jobs of 2 or 3 people. You guys know that. And that's a lot of stress. COVID made people go home and take stock of their families and take care of themselves mentally and physically. And that's why you're not seeing people return to work in the numbers that you want. Because our capitalistic society, which I'm not knocking, I'm just saying, we got to rein it in. People are more important than products that bring in money to a few. We have to take care of ourselves.
Wow. Which brings me back again to this piece of transparency and measuring. Ever since that came out in this discussion, it's been whirling through my head. You know, how are we going to measure success? If we define anything, how is that going to be done? How are we doing it now? We're obviously doing it to some degree now. What do we do with that information? In your experience, particularly those professionals in the medical field, what are we doing with that information?
You realize that we weren't counting Black people with COVID at the beginning of the epidemic. That call had to come out. And when that call came out, we saw people of color disproportionately affected because they were using jobs, they were working jobs where they were exposed to one another, doing essential labor. They were on transportation systems that exposed them. Other countries of the world, and we still in the United States, we're #1 of COVID infections in the world. Mm-hmm. Other countries in the world paid their workers to stay home and gave them their salaries as they recovered so they would not infect other people. We didn't do that. We did not offer people that. So we wound up locking down our economy and found that wasn't sustainable. And now we've opened up the market again. We've handicapped our governor so people don't know that the whole freaking state is in the red for COVID. We don't know that because Governor Andy can't tell us that anymore. We have to figure out a balance between taking care of our citizenry. You know, a chain is only as strong as its weakest link. Everybody in this country has a contribution. Everybody in this country was made, and forgive me for saying by God, and he made everybody individual and they each have strengths. And it's our challenge to find them and use them.
Which, Senator, as I mentioned earlier, I have the blessing to be on the payroll of AARP, but hundreds of folks similar to Pastor Wooley are volunteering. They take this as a key part of their legacy of bringing an end to these disparities and bringing equity to our healthcare and wealth accumulation systems. I think that is something that we will be looking to more and try to learn from these giving people that see the need in our communities and are doing it out of the goodness of their heart and their view of the betterment of our community.
Are we seeing enough people doing the right things? Are we headed in the right direction? What's your sense of that? We've had this whole discussion about disparities. We've had this discussion from the standpoint of policy, from the standpoint of treatment, and some area of specialty. We've talked about it from the standpoint of institutions and organizations that are focused on disparities, particularly 50 and above. My question is, and I think I already know the answer, but the question, do you get a sense that we're headed in the right direction? I'm not asking whether we're doing enough. I'm asking, are we headed in the right direction in terms of dealing with questions of disparity, of health disparities?
I think in my mind is twofold answer to that. And I think that Black Lives Matter really, that whole movement has done a lot for health disparities and bringing recognition to that. And you've had a lot of people, nationwide to get involved with that. I think that was, and mentioning the Nortons and what they've done in the West End, all that was part of Black Lives Matter, I think, in helping to highlight and put a focus on health disparities and what needs to be done in the zip codes that Karen talked about. And so I think that you're seeing more private institutions getting engaged. You're seeing more people doing that. But the other focus, though, apart is the government that you mentioned. I think one of the big issues with the government, and you can talk about this last bill, the climate change bill that we talked about. I mean, it was down party lines. And so that's one of the biggest issues, in regards to helping to fix the system when you got such polarization. You talked about the insulin cap, and that was voted against by one party totally. And so that's one of the biggest issues in regards to accessibility that we talked about, costs that we talked about, and all of that. When you don't have a true functioning government for the benefit of the people, and perhaps you can shed some light on that, Senator Neal, in regards to, do you see that getting better? Because I think that's a big part. It has to be a big part in things getting better, when you can get better cooperation to pass these laws that are needed, nationally to make things happen. The whole Roe versus Wade, you've seen what has happened with that. And that takes a step back from accessibility and all of that. So it's twofold.
Well, let me just say this, that I think it's a mixed bag. I think we take 3 steps forward and 2 back, depending on the subject matter. I think we can't stop from pressing forward, but I will say this: if I haven't gotten anything from this discussion here, I've gotten this, that this is a very complex and entrenched problem. And it goes back to what Pastor Wooley said. We're going to have to put a full court press on this. It's going to take all of us engaged at multiple levels. And with that being said, I want to thank each and every one of you for participating in this AAI, AARP of Kentucky forum or summit on health disparities. I want to thank individually Dr. Karen Krigger for a very insightful contribution to this discussion. Dr. Louis Hargett, who always provides a level of understanding and clarity in terms of his experience in translating that in direct and in common terms. Pastor Wooley, yes, we all have to get involved in this, no matter what the level is. This is a full court press. It is a heavy lift. And Ron Bridges, I want to thank you because institutionally, the whole reach of AARP across this state and across this nation is an invaluable tool to continue the struggle for dealing not only with healthcare needs of all people, but particularly eliminating, to the extent possible, health disparities across this city and across this state. With that being said, I want to thank everyone for viewing AAI one more time on these issues. We're going to be back soon with other issues that we think will be of interest to you, and we encourage you to keep on looking. But we want to leave you with this one thing: do the right thing. If we do the right thing, we can get this done.
Yep.
Thank you
Yep.
so very much.
Thank you.
Thank you.
Thank you, Senator.
Bye-bye.
Bye-bye.
My pleasure, everyone.